for coming here, and thank you to Dr. Prateush Singh for kindly agreeing to do this event. Dr. Prateush is an NIHR academic clinical fellow and ST4 plastic surgery registrar at the Royal Free Hospital. He graduated with distinction from Trinity College, University of Cambridge, and undertook research at Johns Hopkins University, vascularized composite allotransplantation lab before undertaking clinical training in London. He is now the editor of a book on plastic surgery hand trauma and is now focusing his research interests through a PhD on artificial intelligence in facial reconstruction. So off to you, Dr. Prateush.
Great, thank you guys. Just to double check that everything's working and you can hear me fine.
Yep. All good.
Okay, perfect. Great. So firstly, thank you, Sid, for reaching out and asking me to give this talk. Initially, Sid kind of just gave me the brief of just talk a bit about academia and surgery. So I thought I would start with speaking about who I am, what I do, what my actual job entails, and a little bit about how I got here and tips and tricks, things that I wish I'd known along the way. So as Sid mentioned, I'm a plastic surgery registrar and I work currently at the Royal Free Hospital in London. So I think a lot of you on the talk will be medical students. There may be a few of you applying for med school, and then certainly those on the track to becoming registrars or registrars already on the track to consultancy. So, play this. So the aims of the talk I thought I would summarize will be what the plastic surgery academic clinical fellowship is actually like. Talk a little bit about a day in my life and what my week to week looks like. The additional roles that you're expected to do and to undertake as a plastic surgery ACF, what your expectations are from an academic and a clinical perspective. And then something which I spoke to Sid about, which may be of relevance to some of you, is actually the realities of being academic as well as clinical, the pros and cons of this pathway and how it compares to a normal clinical pathway. Then I'll talk a little bit about how I got here and my timeline, things I wish I'd known, and how I would advise you target your dream job from as young an age as possible. So my current job, so I'm a ST4, which means I'm my second year of specialty registrar. Officially, my ACF job is split 75% clinical, 25% academic. Unofficially, my time is 100% clinical and 100% academic. You are expected to squeeze in both and do the best of both on this pathway. Academic leave is something which is unique to the ACFs and ACL pathways. It gives you protected time to carry out your research, carry out writing papers, projects, writing books, etc. And that can be either as a 3-month block in one of your 3 academic years or as a day a week, depending on your unit. Now, your academic time is funded entirely by the NIHR, which means it's at base pay only, so people will always take a pay cut during their academic blocks. The main advantage of being an ACF is it's supernumerary, which means you have more of a free choice about where you go and do your specialty training. Within London plastic surgery, at least, is a pan-10 specialty, which means you have the choice of going to various different units. As an ACF, you're technically supernumerary, so you have preference of your unit allocation. So, a day in the life. This is very department specific. I work at the Royal Free, which is a strong academic centre for plastic surgery. It's tightly affiliated with UCL, and we have an entire block on the 9th floor, which is just for clinical research, which means that my clinical rota is, let's just say, very flexible when it comes to academia. This isn't the case with other units. Places like Mary's or the Royal London big trauma centres, you're expected to have significantly longer hours clinically, which is excellent for your clinical training, but it does mean that getting academic results are a lot more difficult to achieve. Now, we're allocated a consultant every 4 months, which we rotate through, which is a good amount of time to get familiar with their areas of subspecialty. So, for example, at the moment, I work for Mr. Panaya, who is a craniofacial and skin cancer consultant. Prior to that, I worked for Mr. Sajitra, who is a breast and microsurgery specialist. So I get a good flavor of things, which is good for the GMC curriculum of specialty training, which I'll go on to talk about a bit later. Now, because I work for these specific consultants, I do have to do particular clinics for them. And that usually is 2 clinics a week, usually broken up morning and evening. Now, these units are not always in our home unit at the Royal Free, because surgery specialties, which some of you will be interested in, have huge catchment areas. So plastic surgery is confined to about 5 or 6 units in London, which means we cover a lot of peripheral hospitals, a lot of DGHs, which means you have to travel there. And it's often difficult. For example, I live in East London, but I sometimes have to do clinics out west in Hillington, for example, which is an hour and a half commute. So something to bear in mind if you're looking at tertiary specialties. Then we have one consultant-specific list a week. At the moment, things have changed because of COVID, but thankfully my consultant does a lot of skin cancer work as well. And as you know, cancer doesn't wait for anybody. So we still have one full list per week. Now, having a list doesn't just mean it happens. It means as the registrar, you have to organize that, which means organization with the secretaries. You speak to the theatre coordinators, you call the patient. I often have to just call them off my mobile a lot of the time. You speak to collaborating surgeons. So for example, this week we have a big groin dissection case, which is extending into the abdomen. So we've had to ask a vascular general surgery consultant to come and assist us with that, because plastic surgeons don't, in this day and age, have that much experience intra-abdominally. And then preparing the actual theatres, getting the adequate equipment, takes up quite a chunk of my week. Now, on top of your consultant-specific weeks, you also have trauma theatre for plastic surgeons. So you normally have a list every 2 weeks. And then you have to fulfill your commitments to other consultants and other clinics, which is usually about 2 of those a week. Now, as I mentioned before with the peripheral units, we don't just do clinics there, we also do minor ops and full operating lists. So our consultants, for example, will have operating rights at the National Hospital of Neurosurgery, Great Ormond Street, for example, but also other units such as the Lister, Luton Hospital and Mount Vernon, where the registrars will often have to go either alone to do local anaesthetic operations or with your consultant to assist. Now, those are just the clinical commitments during my week. As an ACF, you then have additional workload, which pure clinical registrars don't have to do. A lot of ACFs will be undertaking higher degrees. As Sid mentioned, I've started my PhD at UCL, and there are significant commitments that come with that in terms of meeting those requirements. Every 3 months, you have to submit reports, you have to have regular meetings with supervisors. You have to ensure that your project is well underway. As an ACF, it's also important to have good student involvement. So with great initiatives like BISA, it's a good way forward, but also through UCL, which is our affiliated academic unit, getting you guys involved with projects takes up some of my time as well. Then the actual managing the project, data collection, analysis, write-ups, etc., takes time. And something that I wasn't prepared for was the huge amount of grants and applications for funding that you'll have to do, because you are effectively funding research that you are interested in and you're passionate about, and it is your responsibility to get the money to carry that out. Now, additional roles, as I mentioned briefly, a lot of the department will be senior house officers or F1s who are looking to get into specialty training. And as I'll touch on later, there are a huge number of requirements for that. So helping those guys navigate these often treacherous waters is another part of the job. And the professors that we have are not pure academics. They are surgeons first and foremost, and they are very busy. So for example, my professor, Ashma Sahabi, he is an incredible microsurgeon, but he also leads 3 different master's courses at UCL. He supervises a number of PhD students. I am one of 6 academic fellows in our department alone. So they're very busy, and acting as a liaison between them and people who are interested in working on projects also takes up quite a bit of time. So the expectations of ACFs. Some ACFs already have higher degrees, they already have PhDs. So their goals will be different to people like myself who are clinical first and have come into academic training a little bit later and don't have higher degrees yet. So the guys who already have PhDs, their goals will be to secure the next level of NIHR training. That's an ACL, or an academic clinical lectureship. Their time will then go from 75% clinical, 25% academic to 50-50. And that academic clinical lectureship will see you through to consultancy or at least certificate of completion of training, your CCT. The goal during your academic clinical lectureship, or at least soon after your CCT, would then be to apply for, hopefully successfully, a clinical scientist fellowship, which is a 5-year fully funded program by the NIHR, giving you the time, freedom, and resources to develop a lab of your own and see through research to a higher level. The chaps who already have PhDs will often go and take their academic block postdoctorally for research fellowships internationally. One of our ACFs currently is at Stanford doing a postdoctoral fellowship. Now, coming back to those who are a little bit more junior academically, so people like myself who haven't yet got PhDs, the role of the ACF is to give you an opportunity to develop a good project. It gives you time and resources to develop a robust proposal. Now, when you're signing up for a PhD, it's not as straightforward as simply going to a unit and saying, I want to do this project, here's my money. You have to have your project's proposal peer reviewed. You have to have a number of supervisors, one of who is a full academic member. So one of my other professors, she is a full professor of experimental psychology at UCL. Whereas Prof. Masabi, on the other hand, he's clinical first, based at the Royal Free and UCL, but now the rules have changed. You have to have one of both. You then need to collect preliminary data during this time and secure funding, which I mentioned is a big thing. And speaking to one of my colleagues who's just got an academic breast consultancy job, she told me the other day, the first thing you need to be prepared about when you're going into academia is to get a thick skin. I mean, I've had a number of grant rejections myself. I'm sure a lot of you will have had papers rejected. It's just about putting that aside, learning from it and moving on. Nothing's ever wasted if you learn from something. Now, every year you will have an ARCP, so an annual review of competency, and that will be to check that you're fulfilling your academic requirements. It's quite vague as to what they're expecting. It's not like, have you published a paper? Have you completed an audit? It's more of a wide space question, and it gives you the freedom to justify what you've done with your academic time. And you will have an academic on that board, a professor from another unit who will be scrutinizing your work. So you do have to churn something out with your time. Now, clinically, you have to match the requirements of a pure clinical registrar, but just in 75% of the time. So the GMC has put out particular syllabus on ISCP for your CCT requirements. And I've just taken a couple of screenshots here. I don't want you to read the details. I've just circled what's important. And if you can see here, Appendix 3 shows critical conditions, level 4 CBDs and KEXs. So CBDs and KEXs, for those of you who aren't that familiar, are case-based discussions and clinical scenarios, I think. Effectively, you have to write a vignette about how you have dealt with this particular case. And there's a list of critical conditions of burns, neck fash, major deglovings, revascularization, compartment syndrome, etc. You need to deal with this and submit these to consultants for approval, but they have to be level 4. That's the catch. You have to be at the level of consultant and all of these conditions. Then you have to get your index procedures, and there's a list of those in Appendix 4. Again, those need to be PBA, so procedure-based assessments, which again are just online assessments, but at level 4. So you need to match these requirements, and you need to show that every year you're fulfilling an increased number of those. Working at units during pandemics especially, it's very difficult to get these numbers. You will have to come in on your own time. The next step of any clinical specialty trainee is your FRCS, whether that's in plastic surgery or any other specialty. Generally around ST6, you will have to start preparing for your exam and hopefully sitting your exam. It's very time consuming. You have to be nominated by your consultants to even go for it in the first place. And a lot of things are dependent on you passing that exam. First and foremost being your clinical fellowships. Now, these are some things you need to start thinking about early. They are an opportunity for you to develop skills outside your home unit. A lot of people take the opportunity to go abroad and they do incredible fellowships in niche units that are world-renowned. And if you're thinking the long term here about your consultant job, there is always going to be a bottleneck. Now, the first bottleneck in my experience is, it's at every level, but the major one you will all notice is getting into specialty training. If you get into a specialty which is more competitive at SPR level, like plastic surgery or ophthalmology, then there's obviously fewer people at that level. There are fewer people then applying for consultant job, but there's still a bottleneck. If you're applying for something where there is still a bottleneck at SPR, but it's less so, like general surgery or orthopedics, where a lot more registrars are required because it's more of a district general specialty as well, then you'll be at even more competition to achieve the consultant job in the unit that you want. So these fellowships are super important. You then, as I mentioned earlier, have to fulfill your daily commitments to a higher level, filling out carrying out your clinical commitments, your theatre lists, attending multidisciplinary team meetings for your patients, and ensuring everything is organised and smooth for your consultant takes a lot of time. And again, your ARCP, if you're an academic, you will have a combined ARCP with an academic professor on that panel and clinicians. If you're clinical, you'll just have clinicians. Then I've just taken a little snippet out from an Imperial website about the training pathways, just showing you that every year you will have an annual appraisal. Now, the pros and cons of an ACF. I wanted this talk to be very real and give you a true insight into the additional requirements that being academic poses, but also the additional benefits. When I was in medical school, it was always about get a number and get an academic number. It's more prestigious, you get more out of it, but it comes at a cost. But first, let's talk about the benefits. Firstly, you get to help people. It is rewarding, and let's be honest, that's why we all went into medicine in the first place. You get to help your juniors, you get to see them through into numbers, and when they become your registrar colleagues, it's just really nice to operate and do clinics with your friends. You learn how to balance your time, you learn how to balance your projects, and you take those skills with you into everything else in life. There's a lot of support. If you're at a good unit, like the Royal Free, for example, there's plenty of support we have 2 professors of plastic surgery and a bunch of other ACFs within plastics and other specialties as well. So you get a good community feeling. It keeps things entertaining. I love being in the operating theatre. I like academia. I like to do both. Otherwise, I think if I was doing just one thing over and over again, it might get a little tedious. You do get involved with developing your department. And if you embed yourself into a good department and you can see yourself working there for a long period of time, it is rewarding to see it grow and become enriched with work that you put into it, things, projects that you've organised. Now, being an academic, it does inevitably give you a strong basis for future progression, especially within the NHS. It gives you an extra kind of feather in your bonnet kind of thing. It gives you something additional because it is competitive to get into. The other benefit, obviously, is you do get protected time. If you want to take that protected time, you can. It's not an obligation. You have to bear in mind that taking 3 months out means taking 3 months out of 1 4-month rotation with a particular consultant. These consultants are very experienced and they have a lot to teach. And as I mentioned before, you have a lot of clinical commitments. So whether you actually take your 3-month block is another matter entirely. And also being supernumerary, you have a better likelihood of getting the unit of your preference. Now let's talk about the cons. It's so important to find a good supervisor and a good mentor, and it's really important to do that early. The chap who runs the Academic Clinical Foundation program and the ACL program in plastic surgery is Prof. Ashma Sahibi. You're not going to find a better mentor. So if you're interested in plastics and academic plastics, I would suggest you reach out to him. I've had friends at other units in other specialties who've been academic who haven't been as lucky with their supervisors, and it has caused a lot of stress and anxiety. And one of my friends actually left academic training because of it, because you will get directed down the path of a project that you don't love. On the other hand, if you have a good supervisor, he will encourage you to do a project that you love. And it makes all the difference because you'll be spending a lot of time doing this project. Now, the time commitment is significant. As I mentioned, you have to fill in a lot of stuff in a small amount of time. And with that comes significant opportunity cost, whether that's personal, not seeing your friends and family as much, or you're missing out on other skills, developing managerial skills, doing an MBA, developing leadership skills, going abroad for fellowships. Because you have less time, you just have less time to develop other skills. Now, the whole role of an ACF is to allow you to create a robust proposal to carry out higher research, which then may mean you take time out of training to do this research, which can lengthen your time to consultancy. Now, you've got to bear in mind, when you reach that CCT and you reach consultancy, you want to be good at your job. You want to have some fellowships under your belt. So it's not a race, but you do want to have that end goal in mind as well. Now, being an ACF in the department has higher expectations, I think, than being pure clinical, simply because you've gone through a slightly more vigorous selection process, and you are expected to meet certain requirements of the department in terms of academic output. The next con, as I mentioned before, is funding. You will have setbacks. You just got to keep plugging away at it. And then the last thing, obviously, it is very competitive to get into. Obviously, there'll be an element of luck, but good preparation will go a long way. Now, just to talk about the training pathways, in the NHS in the UK, there are clinical and academic pathways, and they run in parallel, and you can jump between them. Now, when I was a medical student, I thought you either choose one or you choose the other. And I thought, well, I'll hedge my bets, and I applied for the academic foundation program, and I didn't get it. And I thought, well, that's me set. I guess I'm going down the clinical route, and that'll be it forever. That's not the case. You can jump between the two, and sometimes you may have to, even if it's not your choice. For example, I am an ACF. It's a 3-year program that will take me to the end of ST4 into ST5. If at that point I take time out, I can do my PhD. Getting into an NIHR academic clinical lectureship is the next step of an academic training pathway, and it is PhD dependent. So I have to get a PhD before I can apply. If I don't have a PhD and I don't want to continue taking time out to do a full-time PhD, I go into ST5 pure clinical. So I have jumped between the training pathways, and that's totally fine. And the default pathway is clinical. If you want to go into academia, you have to make a conscious effort to go that way. Now, how I actually got to where I am. So I went to medical school, like all of you guys, and I did an intercalation in neuroscience. And at that point, I'd read some inspiring books like Phantoms in the Brain by Ramakrishnan, which some of you may have read, and I really wanted to be a neurosurgeon. And in Cambridge, it's 3 years of preclinical and 3 years of clinical. And I hadn't, to be honest, taken the initiative to find out what being a neurosurgeon was actually like. So I thought I did 2 years of basic sciences for my first year and second year. Then I did my BSc in neuroscience, and it really wasn't for me. I didn't like the basic level of kind of neurocircuitry, etc., the lack of clinical relevance, and it wasn't related to neurosurgery at all. Then I went to neurosurgery, when I was 40, I went to neurosurgery theatres, and I realized that actually I didn't love the theatre either. It's a lot of work to get in, to get access to the brain. The outcomes generally are poor. There's a lot of trauma, a lot of cancer, a lot of hemorrhages, poor outcomes. It wasn't for me. If I had taken the initiative in my earlier years to find out what specialty I actually wanted to do, I think I would have taken a different choice with my intercalation. But anyway, so then I get to the end of my med school, and I applied for the AFP, which I didn't get into. So then I applied for the clinical route into F1, F2 in London, which I did. Then I applied for my core surgical training, and I spent my core surgical training first year at the Royal Free Hospital, second year at the Royal London, and a little bit of general surgery at Barnet before starting my registrar number at the Royal Free. Now, this is kind of what I really wanted to touch on, is what I wish I'd known at each of these stages. As you can see, I didn't take an F3. There's no harm in taking an F3 or an F4. I'm sure people have personal reasons for doing that. Now, medical school, kind of, for some of you, I imagine you're at different years. I'd like to go through each of the years and what I would recommend if I know what I know now. So in my first 2 years of medical school, I would suggest that you just settle in. You embed yourself into life, social life, and work, and you learn how to learn. I think that's the main thing. When you're in school, you're spoon-fed often. And where I was at university in Cambridge, we had tutorials 3 times a week with professors. So you would sit down in a room and they would basically discuss the week's lectures for you, which was still kind of spoon-feeding, but you learn how to learn. And you need to learn how to pass well, because medical school and getting through medical school shouldn't be the only thing. It should be something that you're expecting to do, because you will have to do a lot more if you're looking to get into specialty training and especially academic training. So create a strong base with your academic work to start with. Now, your third year or fourth year, depending on your university, is your intercalation year. And as I mentioned before, don't make the mistake I made. Really think about what you want to do with this year. It's time now to start thinking about where you see yourself being a registrar, what field you see yourself being a reg in, where you want to work as a consultant. And you need to have an idea about where that's going to go for you. And you should choose an intercalation that you will enjoy, knowing that it will take you to your end goal. Now, when I was in my second year, the MB PhD programs were all the rage. They were, we only take the best, and it's very competitive to get into. And at that point, I thought I didn't really love the research, and I didn't want to be behind my mates by 3 years. So that was the reasons. But looking back in hindsight, I think I'm glad I made that choice. And I think you really need to ask yourself, as a third-year medical student, are you set on this career? Are you set on this area of study and this research? Because if you're not, you can spend 3 years doing basic sciences research at university. And if you want to be an orthopedic surgeon and you want to be a clinical surgeon and you have no relevance to, for example, diabetes, you've wasted 3 years, really. Doing a PhD shows you have certain skills, but it's more you're demonstrating tenacity. If you do a PhD in a field of your specialty, that'll count for so much more. The other side, the flip side of doing an MD PhD program is your funding is generally secured by the professor of your lab. You don't have to worry about funding for 3 years. You get more time at university if you have other commitments. If you're an elite sportsman or a musician, for example, and you want to spend longer at uni, then it's a good opportunity to gain something with that time. And it inevitably does put you in a better position. When you come and apply for foundation, core surgery, specialty jobs, and you have a PhD, it's generally 3 extra points, tick, tick, tick. And those points do count for quite a lot. But there are easier ways of getting those points. Writing 3 papers is a lot easier than spending 3 years doing a PhD. Moving on to years 5 and 6. This for me was clinical, well, 4, 5, and 6 was clinical school. And it's very different to basic sciences. A lot of you may be in programs that are integrated with clinical and academic, which is great for you. For me, it was pure clinical, and it's really important to throw yourself into the wards, clinics, theatres, get a real idea about the job you are working for and planning on getting into. Next thing I'd recommend is start early on planning an elective. As Sid mentioned, I did mine at Johns Hopkins University in the laboratory of vascularized composite allotransplantation, which is effectively multiple tissue transplant, so hand and face transplant. And getting to America, doing research out there, it's expensive. But for grants, there are lots and lots of grants. And if you apply early and you have a good idea about what you want to do, then you will get enough money and more to go out there and do it. And you won't have to worry about the expense or student loans or taking loans of any other kind. So start early. And I'm happy to be contacted. I'll leave my details and then talk to anybody who's interested in which particular grants I applied for successfully. The next thing is student sector components. This is an initiative a lot of schools have, which allows you to spend more time in the area that you're interested in. So get to know your team, integrate well into that team, work hard, find the consultants that are happy to teach and that produce results, and stick with them. One of the first people that got me into plastic surgery, Mr. Tariq Ahmed, is a plastic surgeon at Adam Brooks. And he was an amazing mentor for all of us students. Everybody used to gravitate to him and everybody got a lot out of it. So choose who you want to work with and choose them well. Then kind of coming on to be efficient with your projects. You see a lot of medical students volunteering for a lot of projects, and I did the same thing. And you do a lot of work, but you don't necessarily see the results. So what I want all of you to do is, if you find a project, find a mentor who's a couple of years older than you, one of the trainees, and really try and see one project through to completion so that you have a presentation and you have a paper out of it at the end of the day. Next thing is get a logbook. E-logbook is great. It's what everybody uses. It connects to your GMC once you have a GMC number. And it's a good way of recording all your operations, which you will need for core surgical training application and every year of your annual appraisal to demonstrate the numbers you have, especially at CCT. In your 5th and 6th year, start doing teaching skills courses. Cambridge offered some for all of us. There were default courses that we all had to do. I didn't realize at the time the real value of that course. Not only do you get better at teaching, and you can therefore teach first years and second years, and therefore learn more yourself, but I'll come on to an F1, I would advise all of you to develop a teaching program of your own. And having these skills with you gives you a tick box and the ability to set up a program and officiate it with a university. Next thing is ask for help. If you don't speak to your SHOs and registrars, you won't know what they know. People like Sid and he's reaching out to me to give this talk is a great initiative. Use the same initiative, speak to the mentors in your field and get the people to help you. Then you have to decide on where you want to be for foundation training. This is a personal decision for each of you, whether that's being linked to friends, family, partners, or wherever is the best training for your field. Spend some time thinking about that and also enjoy yourself. It's your last year of school, it's not going to come back. Right, moving into F1, throw yourself in. Just get involved with actually being a doctor. There is a lot to learn that you won't learn at medical school. My F1 year was at Basildon, small DGH east of England, and East London in Essex, and it was not a teaching hospital in that sense. It was a smaller unit, very work. I learned managing wards overnight, almost on your own. It takes a lot of time, but you learn a lot, and it makes you a well-rounded doctor. When you eventually become a registrar, you don't want to have the reputation a lot of surgeons in particular have, not being able to manage simple things like pneumonias and DVTs. You want to be good and solid, and you will develop those skills in your F1 year. The next thing to do, I'd recommend, is get your MRCS-A out of the way. It's a written exam. It's a straightforward exam. Find the other F1s who are doing it with you. Get the question banks online. You can even share them with your mates. Sometimes even your libraries will give you funding to get question banks, and just get it out of the way. The next thing I mentioned is develop and deliver a teaching program. And that comes on to one of the latter points is when you're an F1, speak to your core trainees and ask them for their score sheets. Ask them for their application forms, because that will give you the exact criteria of what you need to do to get into core training, which will be your next step. And I think from the top of my head, it's design, deliver, and lead or something. There is a particular phrase for a teaching program, and you need to fulfill each of those 3 points to get the 3 points on the application. So if you use the skills from a teaching program that you would have acquired as a medical student, apply that. I think an idea for all of you can do is what I did is I felt that leaving medical school, I wasn't that well equipped to deal with medical or surgical emergencies. So with a bunch of mates in F1, I designed a teaching program for medical students on managing emergencies. I got it affiliated with UCL. I got it signed off by the clinical lead, and I delivered the program with my friends, and all of us gained these 3 points. So that's an idea, but I think you really should get that out of the way, because you don't want to be doing these tick boxes when you're an F2 applying for your core training. The next thing is completing loop audits. I spent way too much time doing audits and not completing the loops. If you don't complete the loops, you don't get the points. So you've already done the work to get the first loop out of the way, wait a few months, do the second loop, and just see it through. It's more important to finish a complete loop on one audit than it has to have 2 or 3 half finish ones. The next thing is to explore your specialties, spend time in theatre, speak to consultants, they'll give you good advice, and they will develop your manual dexterity skills. It's all well and good doing basic surgical skills, which everybody will do as an F1 who's interested in surgery, but actually going to theatre, having a consultant tell you, giving you the advice of their years is invaluable. So take the time to go there. Don't just bury your heads in the books. And start building a folder. This is something I didn't do. So come F2, when I'm applying for core training, and I have friends who've been like, oh, I've got this massive folder that I've been preparing for medical school, and I have nothing. I just have loose letters in random folders. I have email trails. I don't have a folder. It's stressful. If you start now, every award you're given, every distinction, prize, audit, presentation, paper, print it out, keep it in a folder, and I guarantee you when you come for core surgical training and it's already there for you, you'll thank me. Onto F2, get your MRCSB out of the way. You guys are fresh out of medical school. You are probably going to be the brightest all-round academically that you will be at this point. Don't wait. People always say, oh, you need to have a bit more experience in surgery. You should do your MRCSB in core surgical training. It's not true. Just get out of the way, and then you have to worry about it. And then you will be a mister. And it's pretty fulfilling to write mister and not having to worry about any more exams until FRCS. Again, get the score sheets and target gaps in those score sheets. Use your F2 year to fill the gaps so that when you come to core surgical training, you have 4 points. There's no real reason for you to not have it if you're all passed. Then you have to decide, I guess all of you on this talk are interested in surgery, whether you're interested in core surgical training or if there's a run-through. And run-through training is either ST1 or ST3. So find out what specialty is. If it's cardiothoracics or ophthalmology, it'll be ST1 run-through. If it's anything else, it'll be, well, generally ST3. I think ENT for the past 2 years have introduced a few run-through numbers from ST1. So speak to the heads of the program and see what you need to do for those specific applications, because run-through applications may be a little bit different. Then it comes to ranking jobs. When I remember sitting down on my lap with thousands of core surgical jobs and not knowing if I should rank it by location or by job preference, some years giving me more plastic surgery experience. At the end of the day, it's a personal decision. You rank where you want to go and what job you want. So that's up to you guys. And interview preparation. Learn how to structure your answers. If there are 3 words that I can give you for interview prep, it's camp, spies, and star. And those are for every question. If you structure your question, your answer, you will be, there's no way you'll miss anything out. It's the same way that, let's say, if you use an anatomical sieve for answering your surgical questions, then you'll get everything. So for example, questions based on use, if I was to say to you, where do you see yourself in 5 years' time? I would want an answer that addresses clinical, academic, management, and personal. So have one example for each of those. SPIES is for a scenario, difficult scenario. So for example, you see your colleague drinking on the ward, for example. Seek information, patient safety, take initiative, escalate the issue, and support your staff. And then STAR is for those questions which require an example. So situation, task, action, and result. So if you structure your answers in your mind for surgical interviews, you'll be great. Also, once you get in, there's often a steep learning curve, especially in tertiary specialties. If you're a plastics SHO, you'll be doing that on your own. You'll be doing trauma clinics with some supervision. If you are general surgery, for example, you'll have a good amount of information from med school, but you will be expected to see the patients in A&E, to create robust management plans, to start management, to get the patient up to theatre. So you should really spend a lot of time doing the actual clinical job and not just preparing for the interview for the next step. You will have core competency requirements. If you guys have had a talk by Ms. Stella Vig, who was my program director for core surgical training in London, she will tell you there are a number of requirements that you have to hit, including particular numbers, particular cases of theatre, and whether those cases are STU, so supervisor trainer unscrubbed, or STS, supervisor trainer scrubbed. So the way that you do the operation is also important, and that can all be registered on your e-logbook. And you see a pattern here. You get the registrar that you're friendly with to give you the application form and the score sheet. And again, find the gaps, plug the gaps. Now that you're in training, you are more likely to be working in a specialty of your choice. Do projects in those fields. Some people do PG certs in medical education. If you're interested in doing this, it will give you an extra point. It will take up time. But partner universities may offer discounts. For example, if you're in London, the Surgical Innovation Masters, starting as a PG cert, is heavily subsidized by Imperial. So something to be aware of. And you'll need particular courses for points. ATLS, Advanced Trauma Life Support, and general surgery in particular will require CRISP, so care of the critically ill surgical patient. Here again is a mistake that I made. I wanted to get out of the way, and I booked it in F2. And usually there are 1 or 2 spaces per course reserved for F2s. The thing is, I didn't need CRISP for core surgical training. It didn't give me any extra points, and I forked out 1,500 quid. And I actually figured out later I wasn't able to claim back in study budget because it was retrospective. So what I would advise you to do is to book it in F2 for the course to take place during your CT1 year, so that you can claim CT1 study budget to pay off the course and you're not £1,500 out of pocket. Core training 2. Prepare your application early for a registrar, and then don't worry about it. Get your portfolio ready and then focus on the job. Build up your numbers. The most important thing clinically for SPRs applications is your clinical numbers. At my unit, for example, Royal Free, we're one of the largest centres in the UK for hand trauma and breast reconstruction, but we're not a burns unit. So in order to get burns numbers, which form about 25% of your application for reg, it's worth taking time out going to a burns unit like Chelsea and getting some experience, getting some numbers. Find buddies who are looking to apply for reg numbers with you, and develop a question bank from your seniors, because those will be the same scenarios that are often repeated time and time again. And look at the structure of your interview. If you are applying for plastic surgery, sorry, let me go back. The clinical scenarios are where your big points are. If you're doing general surgery, there will be physical task assessments, like lap simulation stations. So get your practice in there. Then rank your jobs by location or by job preference. Certain things to be aware of. At my stage, a lot of my friends are applying for numbers or have numbers. There's a lot of stress about where do I apply if I don't get a number in the first round, for example. Most important thing to bear in mind is you can re-interview. So if you get a number, for example, in Manchester, and you want to stay in London, there is a lot to be said for taking that number, reapplying the next year, and moving straight into SD4 should you get London the following year. Next thing to note is interdeanery transfers are possible. If you have if you're married or have kids, for example, it is sometimes, rarely, but it's sometimes possible to switch your deanery. And the other thing to bear in mind is if you get offered a number in a location that is not your top choice in the first round and you decline that number, there's no guarantee that a number in your first location will come up in the second round of the same year, which means if you turn your number down in Manchester, hoping that number in London will come out 3 months later, and it doesn't, you will get no number. You cannot bank your Manchester number. You start again the next year without the security of a training number. Specialty run-throughs, as I mentioned, can happen at ST1 or ST3. Speak to your seniors, get your score sheet, start early. Academic interviews for ACFs and ACLs are very different to clinical interviews. There's no rotation between different stations. There's no talking about clinical scenarios, this and that. You will have a panel of academic experts and they will ask you your past experience, your project plans, what you've done so far, what you plan on doing in the future, and how you want to use your ACF time. You will have to do paper analyses of 1 or 2 papers. You have to do statistical analyses. So it requires a completely different level of work and type of work. Now, the good thing is the interviews can happen earlier, which means you can apply for both if you're prepared to do the time. If you're applying for a academic run-through at ST3 level, you will often have to undertake a clinical benchmarking interview. So the normal clinical interview you'll have to go through and you'll have to pass. And it's the same for run-throughs from core surgical training. You'll have to apply for an academic run-through, successfully get that post, and then go for the pure clinical interview and secure highly enough to be safe. And then you can take your academic job. So what is my game plan going forward? So I plan on completing my registrar training in Pantem, so that's around London, and fulfilling my GMC CCT requirements. I hope to complete my PhD. Now I've started it now. I may need to take some time out. I'll then apply for an ACL if I get my PhD done in the next few years. And ST6, start preparing for my FRCS and start preparing for fellowships. I'm considering doing something called TIG fellowship, which some of you guys will hear about later. It's called a training interface group, and it's between 2 specialties. So there are TIGs, for example, in breast, it's oncoplastic TIG fellowship, and those are a mix between breast surgery and reconstructive surgery. So that's a good one for people who are looking at breast reconstruction, microsurgery in particular. I then will hope to try and develop some management and leadership skills and decide where I want to work as a consultant, and then eventually apply for clinical scientist award or a clinical scientist fellowship. And the last thing I just recommend to all of you is don't forget to live your life. It's a talk on academia and surgery, but you know, at the end of the day, there's a lot more things that are as if not more important: friends, family, partners, kids, travel, hobbies, etc. So don't forget to do that. Thank you for listening. These are my details. If you'd like to reach out, I'm happy to help, give you advice or get you involved with any projects. And I'm happy to take any questions now. Thank you.
Awesome. Thank you for a very insightful talk, Dr. Prateush.
No worries.
If you've got any questions, you can send them directly to Dr. Prateush or to myself, and then I can ask him. And if you guys can please fill out the feedback form, that'd be very useful. So I think one of the questions that I've been asked was, how can you verify whether you can get presentation/publication out of projects without sounding like you are just doing it for the project's sake? I am genuinely interested in projects, but always intimidated to ask what I can get out of it. That was the question.
Yeah, I think you just kind of have to do it. I mean, whenever I speak to students, I always say, what do you want to get out of this? Because I left medical school with no peer-reviewed publications. I've worked hard on a lot of projects, none of which had come to fruition at that point. And I felt like a lot of time was wasted. And then you look back, you know, a year or two later, and you see things that have been published without your name on it as a student, because you're easy to overlook. So I think if you go in there and you say, this is what I want to get out of it, you're not wasting their time, you're not wasting your time, and you get a project and take just one and see it through to completion. Then I think there's no harm in just being honest. And I think people will respect you for it.
Cool. Someone else has asked, thank you so much. Did you always know you wanted to do research? If not, what do you think students should do?
I didn't know I always wanted to do research. My first love was always clinical and surgery. But as I progressed through medical school, I realized the importance of it, and actually kind of bettering yourself as a surgeon, but also you want to be one of those guys who has the ability to empirically appraise the literature. You want to know that what you're doing is the gold standard. So for me, it was important to get involved with research. So researchers and creating novel ideas, creating progress in your field was interesting for me. And also, I didn't want to do the same clinical work day in, day out. I wanted to have something different. So I always kind of, I developed an interest in research, and I would like to see it through. But things might change as I get older. And so the second part of that question was, what should they do as a medical student?
So if they're not sure about wanting to pursue a career in research, what do you think students should do? I'm guessing to figure out whether they should pursue it or not.
Yeah, I think it depends if you're interested in pure research, pure clinical, or a blend of both. I would suggest reaching out to people who are doing what you perceive to be a good balance. If you're interested in doing kind of half-half like me, then reach out to me, and I will give you a project and you have a crack at it. And if you like it and you enjoy the balance of both, then it's more for you. If you don't, and you realize that you just love being in theatre, then it's okay to also to not do research. But bear in mind that there is a tick box, and there are hoops to jump through, and academia does tick a lot of those boxes, and it's okay to do it for the tick boxes as well.
Okay, cool. And the next question, so I think you sort of touched on this right at the end of your presentation, but they said really insightful to hear about ACF, which seems to be taking a lot of time. So do you think it leaves sufficient time for an adequate work-life balance? And then I'll add onto a bit of that. So how would you recommend getting around that and actually striking good work-life balance?
Yeah, it does leave time for a good work-life balance if you have an understanding and supportive mentor and professor. I'm lucky, I do. Prof. Mzabi is incredible. And because of that, he gives me the guidance that I need to work efficiently, and he directs my project, and he's always there. And so I don't feel lost. I think the worst thing is, and especially when I get students to write papers, I will often just touch base and say, are you okay? Like, do you know what you're doing? Don't feel lost, because how expected to produce something that you have no idea about? I mean, the whole point of research is it's innovation. So if you have a good supportive group, then it is fine. You can have a good work-life balance. And Sid, your second point was how to achieve that balance.
Yeah.
I think it comes with time. I'm not going to deny there've been a lot of evenings when I've been stressed about projects not coming to fruition more recently, for example, but you learn to compartmentalize, and you learn to leave things and delegate things appropriately. And it just comes with experience. You can't be expected to know something if you haven't lived through it. So as much as I'd love to share that with you vicariously, I think you will develop your own balance, your own way of relieving stress, your hobbies, your interests, your friendship circles, and you will find a balance. It's not for everybody, but if you can manage it, then you can benefit.
Cool. The next question is from Sonia. She's asked, hi, thanks so much for the insightful talk. Are there many traveling opportunities in your field of work? If not, do you know of any specialties/routes that could possibly involve this?
Yeah, that's a really topical question, Sonia. So there is scope to travel for everything in every specialty. So for example, in plastic surgery, it's almost expected that you would have done a foreign fellowship. There are certain units, Ganga in India, Taiwan especially, these are huge microsurgery units that if you've been there, it's very prestigious, and you develop an incredible set of skills that you can bring back, and it will enrich your practice as a consultant. Getting funding for those, you can either self-fund, obviously, but there are grants. Grants will be through your specialty-specific bodies, such as BAPRAS for plastic surgery, BOA for orthopedics, BAUS for urology, but also the Royal College of Surgeons offers traveling fellowships as well. And the reason that I say it's really topical is because there are changes happening to the ISEP curriculum as we speak in terms of doing in-training fellowships, and they're trying to stop it. So at the moment, some of my consultants have done fellowships during their ST1 to ST8 years, which has been incredible and very efficient for them. Now that what they would like to increase service provision, obviously, is that you do your clinical training ST1, ST8 in your home unit, and then you do fellowships post-CCT, which makes things, there's pros and cons. You will be leaving and doing your fellowship as a consultant, which means when you get to your fellowship units, you have more authority and more skill. On the downside, it lengthens everything out.
Okay. The next question is about just clinical skills. So they've asked, do you think that ACFs would be on par with registrars that are 100% clinical? And do you think academia could hinder you from progressing clinically?
Yeah, very valid questions. That is generally the snub. If you're an academic trainer, you often hear the brunt of it as, oh, you'll never be as good as the clinical trainees. But actually, you will, because the ARCPs are so robustly made for you. As I mentioned, your clinical requirements and your clinical scenarios have to be fulfilled, and you have to get the same numbers. And if that means coming in on weekends and evenings, and if your friend, for example, has, for example, some friends of mine, if they're on call overnight and there's a revask or a replan to do, they'll give me a call. And if I'm around and if I'm free, I'll go in, I'll do it with them. So you develop your numbers. So your clinical skills are very much your responsibility. If you want to be a surgeon who's renowned for having a great pair of hands, you'll have to put the time in. And I think you can be as good, if not better, because you're often driven more than your pure clinical colleagues. And what was the second part of that question, Sid?
The second part of that question was, do you think academia hinders you from progressing?
I don't think so. I think to be a well-rounded surgeon, you need to have a bit of both. You need to be able, as I said, to critically appraise literature, to make sure you're giving the best treatment. And in fields like surgery, things are changing all the time. You need to be able to look at that. And it may be that your research is not based on a basic science level, but it's more based on a clinical level. If you're interested in clinical trials, if you're interested in innovation in surgery, then it's good to have some research skills to back you up as well.
Awesome. Have you still got a bit of time for questions, if that's okay?
Of course, yeah, no rush.
Yeah, there are quite a few. So Viraj just said, first off, just want to say a massive thank you for such an inspiring talk. What would your advice be for finding and building a mentor relationship as a medical student?
Initiative is the first thing. I mean, Sid and I have known each other on social media for a little while now, and we've talked about projects. He's got me involved with this. He's somebody that I would be happy to mentor. If you take time to go to your unit and embed yourself in the department, get involved with the projects, show your commitment to going to surgery and actually operating, people will be happy because you'll be like a mate. They'll be happy to teach you stuff. So I think if you just kind of bite the bullet and go for it, and not everybody is going to be nice, not everyone is going to want to help you, but very quickly you will find out the ones who will. And if you, in particular, I have friends in different specialties who love teaching. If you are interested in a particular field, just reach out to me or drop me an email, and I will try and put you in touch with somebody that I know who is a good mentor.
Awesome. Yeah, and thank you for that, Dr. Prateush. I'll be sure to follow up on that. Nice. Then there are quite a few questions about the AFP. So the first question was, would you have any tips for applying to the Academic Foundation Program? And do you think it's worthwhile, considering you ended up with an ACF anyway?
Yeah, I think I can give you some advice, but obviously I didn't get it. So I mean, maybe speak to somebody who got an AF to see what I did wrong. But I think if you are able to get involved early with research, it gives you the opportunity to get papers out. And as I said, I didn't have any papers when I went for my AFP interview. So it was very difficult to support anything. The second thing I noticed is that they asked me, there was a clinical scenario station that was trauma scenario, and I churned out my ALS, my advanced life support, and I could feel myself waffling at the time because I didn't have a structured way of answering questions. So if you practice your CAMP, SPIES, and STAR, and if you learn your ATLS algorithm, then you will find that from every interview from now until SPR, you have those questions nailed. So prepare your question structures, get your research, and get some papers, and that will put you in a really good position to do an AFP. And the second part of that question, no, it doesn't hinder you. And as an F1, as an F2, I was always like, well, I want to do research. I know plastics is competitive. If I don't have any research, it'd be very difficult to progress. But I didn't get an AFP, and then it does eat away at you a little bit. And what I want to tell you is, don't let it. I had an incredible registrar mentor, Anko, who's a consultant now. He's a consultant at George's, I think, vascular consultant. And he told me, you can jump back in if you want to. Just because you didn't get one particular job doesn't mean you have to let that dream go. So it's not, if you don't get it, and most of you won't because there are very few numbers, then just carry on and make sure that you are doing everything else that I advise, so that when you come to core surgical training or SPR level, that you're ready to apply for your academic jump if you want to.
Okay. Let me just have a look. There's a question about MaxFac. So somebody said, what advice would you give to a prospective MaxFac surgeon?
Yeah, whatever advice I can give you will be kind of third party. Just a few of my friends are MaxFac surgeons, but I don't know the route personally myself. I know you have to do dentistry, so I don't know if you've already got a dental degree, but I know that King's, for example, offer an accelerated dental program for doctors that's only 3 years. So well, do a PhD or you do a dental program, and then you run through at ST1. I would get involved with peripheral projects, ENT, plastics, even orthopedic, craniofacial, neurosurgery, and any sort of good project in that field will give you enough points to get in, from my understanding.
Cool. And then just going back to the whole thing about ACF without doing AFP, do they ask you at the interview why you didn't do an AFP? Or did they bring that up at all?
They didn't ask me. They asked me what experience I had. And on the application form, there's a white space question for what past research experience do you have? And I'd already condensed it down there, so it was easy. I talked about my elective. I talked about research projects that I'd done for my intercalation year. And I demonstrated the skills that I had developed from that and what I wanted, most importantly, to take forward into the project that I wanted to do during my ACF. They didn't ask me. Had they asked me, I think the best thing you can do is just be honest and just say I applied. At that point, I didn't have the knowledge and experience that I do now. There are certain things I would have done differently, but I don't think it's hindered me because I have been able to do this complete looped audit, this paper, this exam, this course, etc., and that'll be fine.
Okay, and I think one last question that's on here, unless people send in more, is how do you manage committing to a specific project or specialty in order to build a portfolio if you're also into building a diverse set of experiences?
Yeah, so as in, is the question directed at how do you see a project through to completion whilst also keeping a diverse skill set?
Yeah, you said yes.
I think if we go back to my slides about what I'd recommend at each year, it's not always possible to work in your area of specialty. And I don't think you should feel pressurized to do that. So for example, when I started F1, my first film was gastro medical. And in that time, we published 2 papers. Then when I was on psychiatry during my F2, I published a paper or 2. And so when I came to core training, the question was, how many first author PubMed index papers do you have? And I had 4. They didn't ask me what fields they were in. Then when I was in core training, I thought, now I need to really direct my interest surgically. And I was working in general surgery or plastics, and I started writing papers in those fields. I would say, go with the opportunities you have. Don't always be reaching out to other units, because if you don't embed yourself in the unit, no one is going to know you. No one's going to want to help you, and no one's going to see your project through with you. So if you're working in a good medical unit, take the opportunity, write a paper, and just get it done. Don't faff around with, oh, I'll do this draft, I'll come back in a month time. Just sit down, write it, and force your registrar and consultant to review it. And I realistically, if I'm writing a paper and it's a review paper, for example, I'll give myself 3 or 4 weeks and I'll just get it done, and then you can move on. If you let projects drag on, you'll never finish them. So my point really is, take the opportunities you have and the units that you have, and just try and work efficiently.
Awesome. And I think the final question is, where did you find grants to go to Johns Hopkins for research?
Yeah, there are loads of grants available. I don't know which ones are still running, bearing in mind that I did this in 2013, 2014. But at the time, the International Association of Pathology had some grants going. There was a medical dental students union. There are websites basically out there, and whoever's interested, shoot me an email. I'll send you the list that I have. But if you just Google them, just say medical elective grants, there will be people writing about this stuff, and there'll be 3 or 4, and chuck your name in for like a couple of them. Also, my university offered grants for a couple of £100. So just take them all, and it all adds up enough to pay for the international flights and accommodation, etc.
Okay. I don't think there are any more questions, but I just want to say thank you again your time, and thank you for a very insightful presentation with some very practical tips that I think we can all take on board.
Great. No, thank you very much for listening.